in our Title I schools, and that's really where we deal with parents working and access, transportation access. Parents sometimes can't get to the dental office. They can't get time off of work to come to the dental office, not for routine care. They need these children to get as much care as we can give them without them having to be here.
Today at Battleground Elementary in Lincoln County, we'll probably see about 30 children and complete them if we can. If not, we will come back for sealants. And our DAP assistant, I say Dental Access Program Assistant, will call each parent and explain what we did today and that we saw them, and go ahead and make them an appointment to return if they need to.
We take a series of 9 photographs on each child. We then take x-rays that are necessary if the child has not had x-rays or we feel we need to take x-rays. The hygienist on the MDU has an opportunity to utilize a pre-prescribed protocol for taking those photographs. Then all of that, a panoramic x-ray if necessary, bite wing x-rays if necessary, and photographs are stored within the Dentrix system. And literally immediately we can view that at one of our off-sites. So our dental access program navigators can then direct those parents, after talking to the dentist off-site, to get that patient in for the care that they need. And although we only do preventive services, we at least know at that point what that child needs as far as care, and can say to that parent, your child needs 4 visits. Your child needs to go to the hospital. Your child needs whatever care is necessary. And then that navigator can then direct all that care to that doctor.
We've always, as dentists, practiced and consulted amongst colleagues about certain cases that we might have.
Hey, Dr. Madison, it's Dr. Harrison.
Hey.
I just had a patient in the chair, and I just wanted to get your quick consult on a few things.
Okay, no
Let's see if I
problem.
can share my screen.
Okay.
All right. So these are the x-rays that we were able to get.
Okay.
It looks like she's missing a filling in tooth number 31.
Okay.
What are your thoughts on saving this tooth?
And so, when did how long ago did she have the root canal? Do we know?
I believe it was in 2016.
Okay. And how long has the buildup been missing?
About 2 weeks.
But can you tell me if she's experiencing any pain, sensitivity, or it just came out and now she's coming? Does she have the crown with her?
She has the crown, no pain or sensitivity, but the tooth is rough, and so it's cutting her tongue a little.
So what I would do is I would remove the remaining decay and take an x-ray so that we can see how much tooth structure we're actually left with, because it is pretty close to the furcation area. And so once you remove all of that existing softness, if you have sound tooth structure, and if the root canal, sometimes when you do a root canal, it has a floor put on top, a composite floor. If the composite floor is still intact and you don't have any more soft tooth structure, you should be fine to place a buildup. If you feel like you need a post, you could definitely put a post in to place a buildup, and then re-prep for a crown. It's opened up our aspect of being able to treat patients. What I mean by that is that we are now able to talk with someone face-to-face without actually being face-to-face.
Hi, I'm Dr. Harrison. I'll be working with you today via this Zoom call. Can you tell me your name and what's been going on?
Hey, Dr. Harrison, I'm Taylor. I have been experiencing some sensitivity in the backs of my teeth on upper and lower It's on right and left sides. I do have fillings that were filled approximately a couple years ago. I think maybe one of the fillings has come out, or the teeth adjacent to that may have some cavities that need to be filled as well.
Okay. So the sensitivity, is it with hot and cold or when you're chewing?
Hot and cold, and then sweets or salty.
Sweet or salty? Okay. Is this a constant pain?
Nope, it comes and
just
goes.
notice it? Okay. And let me take a peek. So when you say you think that you have a filling that came out, do you think it's the top or the bottom?
For that, it's definitely the top in the very back on the left side.
Okay. And what makes you think that you have a filling that came out?
Where I could feel the material before, it doesn't feel like it's there anymore. It feels more open.
And it feels a little rough?
Yes.
Okay. So I think the best thing for us to do is I'm going to recommend Sensodyne for now, as far as the sensitivity goes, since it's all over. Use the Sensodyne and see if that helps. But in the meantime, we'll also schedule you an appointment in clinic so that we can evaluate to see if that filling is missing. If it's missing, that could definitely cause sensitivity because your dentin is exposed. That's a layer of your tooth that's under the outer layer. And we'll have to get you into clinic and get an x-ray, make sure there's no cavity there, and replace that filling that's missing.
Okay, great.
Okay?
Thank you so much.
I'm going to take a look at your x-rays while I have you on the phone because we have some previous x-rays of your teeth.
Okay.
Excellent. It doesn't look like any of those fillings were very deep fillings.
Okay.
So that's a good thing. We'll get you into clinic, get a new x-ray, and figure out what's going on.
Great. So I should just look forward to a call to schedule my next appointment for in-clinic?
Absolutely.
All right. Thank you so much.
Dr. Rob, are you there?
Hello, Chi. How are you?
I'm good. How are you?
All right. All right. How you doing today?
Great.
Good.
We have Anthony on the phone, and I wanted to ask you a question about his tooth pain.
It was a medical provider. She's a physician's assistant, Chi, and she called. She had a patient on the line who she was just checking on his diabetes and hypertension, making sure his meds were good. It was a regular appointment, but he just made a comment that he'd have a hard time sleeping because a tooth was bothering him and it was a little bit swollen.
We were doing a regular routine visit. The diabetes is in control, and he takes his medicine daily. He's on lisinopril and metformin. But we were just about finishing up, and he mentioned that he's got pain in his lower jaw on the right side, and he's unsure what to do.
Okay.
Probably about a couple of days, but he can give you more information.
I was able to talk with her at first and then talk with Anthony. And really, it helped very much because I was able to speak with him face to face and really get an idea of what the problem was. And I realized it's pretty important, especially for somebody who's diabetic like he was. Hello, Anthony.
Hello, Dr. Ross.
Hey, how you doing? We do have I'm pulling up your record here, and it's been a while since we've seen you. Things have changed a little bit.
Yes, sir.
But tell me about what's going on.
Well, I've had this tooth pain for about 6 days now.
Okay.
And it's really starting to press. Really starting to bother me.
All right. 1 to 10, what is it about on pain?
About an 8.
About an 8.
8.5.
Hard to sleep?
Yes.
Okay. Are you taking anything?
And that's particularly real bad at night.
Ah, okay. Are you taking anything for it?
Well, a couple of times I took some ibuprofen to see if that would help. It helped temporarily.
All right. Anthony, is there any swelling?
It's a little bit, and the gum is pretty sore.
Okay. I think we need to take a look at this thing. I had the schedule right in front of me, so I went ahead and found a slot for him at 2:30 that afternoon to get him seen. But I'm not sure if I would have done that if he would have just called in to our clinic and just said he had some pain. I was able to be a lot more specific. On the other hand, from his point of view, he had not been in here for a year, and he was a little nervous.
And bad as this tooth pain is, Dr. Rob, I do have a few questions with the pandemic and all that's going on.
I completely understand. Things are a lot different than they were a year ago when you were in here last.
Yes.
What kind of questions do you have?
Well, I know it's supposed to be social distancing and everything, and I'm sure that you guys are taking precautions, but I don't know, what do your employees do as far as masks, gowns, PPE? How is that done?
Very good question. Anthony, I'll tell you what, let me walk you through your appointment, all right? Exactly what's going to happen, so it won't be a surprise to you or anything. I was also able to make him feel a lot more comfortable about the fact he's going to be washing his hands, we're going to give him a mask, we're going to be giving him a mouthwash, as well as taking his blood pressure and blood glucose and getting him treated, hopefully. And I think he felt a lot better after that encounter.
Obtained 4 mouthwatch cameras that we're going to be giving away during the event. So Brant Herman, actually, I see you on the event already. So thanks for donating those to us. So we have randomly selected Kelsey Rostu is our program coordinator with the Oral Health Collaborative, and she randomly selected through a randomizer, is what she called it, a program to pull out participants from the event for the giveaway. So those will be announced a little bit later in the event. And then towards the end, we're going to talk about next steps for North Carolina in terms of teledentistry legislation and how you can get involved in the process. I want to make the disclosure known now that applies throughout the entire event. The Foundation for Health Leadership and Innovation and the North Carolina Oral Health Collaborative, any of its staff or affiliates, have no endorsement of specific products or no financial interest with any of the products that may be discussed or come to light during this event. So with that in mind, I'm going to go ahead and start with the panel. And so we have Dr. Doherty with us, Dr. Mattison-Chalwe, and Dr. Donigan, I believe, is joining us as well. So I want to first, again, thank all 3 of you and welcome you to the event. It looks like Dr. Mattison is right out of the clinic, and so thank you for being so flexible to join us today for the Q&A. We're going to spend about 15 minutes in the Q&A, and then we will move on. So I'm going to open the floor now and just see if there are any questions from participants based on the promotion video that you saw. So don't be shy. If there aren't questions, though, we do have some queued up for you all. All right, so we have a shy group with us. We have 100 folks on. No questions based on the video content that you all saw? Let's see here. All right, so questions are coming in from the chat, so that's great. Let's see. So I got a message from Dr. Donigan that I think he is having a little trouble getting into the event. So Brady, can you reach out to him and try to arrange for him to join?
Yes, I'm working on the issue right now.
Okay. So let's move forward with some questions around implementation. And so I'll start with Dr. Mattison. Katrina, could you tell us a little bit about your process? So when you ventured into teledentistry for Piedmont Health, what was that process like for you, and what were the lessons learned so far in implementation?
Hello, everybody. Sure thing. So it was a whirlwind of information all at one time, initially. And so if you don't plan, you don't know where you're going. So the first thing we had to do was look at our process on site and follow that same process and make sure we had every T crossed and every I dotted, so that we were not going to miss steps. But at the same time, we had to work on a contactless approach. So we began to formulate a roadmap or a plan for teledentistry based on what we were already doing in clinic, so that we would have parallelism. It also made it easier to get staff on board, because we were able to have them correlate what we were introducing as something new to what they already had a broad knowledge base on. So the first thing I would say is know where you're going and have your roadmap. And then you have to start step by step and test the process. And so we did a lot of PDSAs in about, I would say, probably a span of 4 weeks. And we're still doing them to make sure that we're improving our process. But if I had one thing to say, it would be know where you're going and have a roadmap, and try and always have something that you can correlate with, so that you can make sure that your process is as smooth as you want it to be.
Excellent. Thank you so much. So this question is for any of the panelists that want to answer. So Dr. Doherty, you as well. What advice would you give to dentists looking to implement teledentistry in their practice?
Can you all hear me?
We can.
All right, great. I would first of all listen to Katrina, because she did everything right, and we did not quite follow the plan and do all the PDSAs. We ended up dotting a lot of T's and crossing a lot of I's, and made a lot of mistakes. And I was just, I'm an old dog, and this is a new trick. And so I think a lot of you out there are a little bit more further advanced than we are, but we're moving right along with it. And I had to be convinced, and I am now, that it's very helpful to our patients and to our communication, especially with our medical and behavioral health colleagues. And what we did was we first started reaching out to patients during, 8 months ago, during the beginning of the pandemic, in an oral health hotline, and we incorporated quite a bit of teledentistry into that. And then we actually piggybacked with our medical, and that helped us so much. And if you haven't really started, I would consider doing that, because during the pandemic, we got a lot closer with medical, because we were involved with them in infection control, and we were doing a lot of the screenings for them because our patient load was down. And as we got closer with them, we found they were quite advanced in telehealth, and they can really accomplish a lot. And I was thinking in my old mind, well, how am I going to do a quadrant of restorations or take an impression over, online? How's that going to work? And that's the hump I had to get over. And fortunately, I'm over that now. We use the same software as medical. So we use Doxy.me. And rather than do this standalone with our own department, which is large, we are tied in with them. And so it's very, very easy for a provider to give us a call, a medical provider, and we just jump right into the waiting room and jump right in on the call and get those patients seen very quickly. And we avoid having to make an extra appointment, like Bill was talking about in the video. We'll get into hopefully into our plans for our school program a little bit later. We don't have a program like Kintegra, but we go into about 18 schools. We're not there yet because we're portable, and so the schools would not like us there yet, but we're making all kinds of plans. And Katrina, we are doing those PDSAs on that one. So we are trying to put the dots on the I's and the crosses on the T's.
Excellent. All right, so I think Dr. Donigan is able to now get in. He's trying to launch. We reached capacity, but we have extended the plan we have for Zoom, and so excited to see so much engagement and folks wanting to be a part of this event. In terms of visualization, so a lot of questions that we get at the collaborative in terms of teledentistry is, what are some tips and tricks that you have used to improve image quality when you are connecting with patients, whether that's synchronous or asynchronously? So Dr. Doherty or Dr. Mattison-Chalwe?
So it was a lot of trial and error. And so I think it was Mouthwash, if I'm not mistaken, who put out a webinar on the teledental visit and how to actually capture good photos, and how we could use our snipping tool inside of our computer systems to actually, you know, snip pictures if we needed to. And then, of course, we also made it a point to try and coach the patient. And we also, in addition to coaching the patient, that might mean one of our team members was on the phone with them while another team member was doing some other things in the background, just to make sure that we got a good image. Because that little camera at the top of your phone, or when you take a selfie, you know, the relationship of the mouth to the actual camera is different. And so we practiced. We also practiced prior to actually implementing teledentistry. We practiced the roadmap. So we had someone be a patient, someone be the provider, and then we just practiced. And if the image was not of good quality, we would politely ask them to retake it. And, you know, everything takes practice, and that's what we did. We definitely didn't want to diagnose over or make an assumption over a poor image. And so our providers and the staff members felt comfortable enough being the liaison between the patient and the provider to say, yes, this is a good image, we can go with that, or no, we might need to rethink how we're going to get this image.
Absolutely. Well, it looks like, thank you, Katrina. It looks like Dr. Donigan has joined us. He's somewhere, not in North Carolina, it appears. But Bill, what would you add? I know, sorry about the little trouble of you getting in, but we're talking about image quality. And so I know that you have a prescribed protocol. Do you want to speak just a little bit about that and kind of what your words of advice would be?
Sure. My biggest thing would be just what Katrina said, practice. We have a prescribed protocol in our schools of 9 pictures, which includes all of the quadrants, anterior pictures, and both canine bite pictures. But, you know, it is all about practice. And I tell the dentists and anybody else, you know, the first time you cut an amalgam, you weren't as good as you are now. You know, it all takes practice, and we keep improving and moving towards a point where the quality of the images we get are what we want. The thing that as I expressed to you, Dr. Bryan, earlier, is that, and I got another one today, our teams are out in the schools, and we get a child who is having pain, and inside of 24 hours, they're in the clinic getting treated, and because they're having pain, and the hygienist will contact our navigator, who contacts the doctor's office, wherever that mobile dental unit is located, and then moves that child in with their parent. So the whole system about retaking pictures, we retake bite wings if they're bad. And guess what? There's no radiation to take in these photographs.
Mhm.
So that would be my big thing.
Good point, Bill. We did have a question in the chat that I think, Bill, you can answer. It says, have any of the dental directors utilized teledentistry in conjunction with portable mobile dental operations for care or education?
We starting in September, treated 150 kids in the month of September. In the month of October, our mobile dental units will treat 38 out of a possible 44 days. They will be in schools treating children. Preventive services utilizing teledentistry every day they're in there.
Excellent.
Hey, Rob made a point, it's very true. The schools won't let you in. In our case, we have mobile units and we sit outside the schools. So the students can walk out of the school, but we can't walk in the school.
Mm-hmm. So that's actually very timely that you mentioned that, because in the chat, another question came in right as you were saying that. It says, are these schools letting people in?
No, emphatically no. And part, you know, it's all about the COVID. It's all about what we do. In our case, we have 2 mobile units that each have 3 chairs. Our staff pull up. The teachers bring the student out to the MDU. The student receives care. The student is returned to the school.
So this other question is for the 3 of you. So when you think of teledentistry in your particular instance or practice type, what is the equipment burden? So is it super expensive to get involved in teledentistry and how you're utilizing it? Is it a relatively low financial barrier to entry? Can you talk a little bit about that?
I'll make a quick comment. On our mobile units, we actually put in Digidoc cameras before Mouthwatch was even available for us. So with Mouthwatch, you're talking a few $100s, $300 or so per camera versus the high-end Digidoc is probably $3,000. So it's not excessively expensive compared to a lot of other things. The biggest thing, and I mentioned this, Dr. Brian, earlier, is that broadband or any type of bandwidth that you need, that's the hardest thing to doing anything synchronously, is how can we access the internet, especially even at schools, because the schools, pardon my language, but they suck up all the bandwidth. And sometimes we're the last one on the totem pole, so.
Mm-hmm. And Dr. Doherty, what about you? What would you say in terms of barriers to entry?
It's not a big barrier for us at all, mainly because we're utilizing systems that are already in place. And one of the main systems for us, of course, is Dentrix Enterprise. Those pictures and those shots, just like Bill was talking about, go right into our EDR. And they're seen immediately at our sites, at all our sites. We're able to pull them up. There's some investment involved with cameras, but the cameras are frankly not that expensive. And there are also grant funds that are available, which we've taken advantage of, thanks to Blue Cross Blue Shield and Duke Endowment and other organizations like that. So it should not at all be a barrier, and we've had the chance to expand it to not just the schools, but also Dr. Lim, one of our associates here, is working with our emergency department. We're using the same kind of model that Bill is using in Gastonia, and we're also using them. We have our IT people are setting up hotspots when our outreach people go to farm worker camps and places like that, so we can get some images from there. And if we aren't able to get into the record, at least we can see some pictures and we can give them some advice on whether we need to get that patient in or not.
Excellent.
And Rob, let me interject at that point. You can, if you have hotspot or broadband issues, you can download those to a transfer drive or a thumb drive and take them direct to one of your clinics and download them. And in our instance, a lot of times it's downloaded by the end of the school day.
Yeah, great point. Katrina, what would you add? Do you have anything to add to that?
So for me, I would just say start small. And by us starting small, we already had almost everything that we needed. We've been blessed to also be able to work with the medical team as well, and they already had a platform. We used the same systems we had, and we just expanded those systems to include teledentistry, which made it a lot easier than just saying, oh, I'm starting from scratch, I need to go purchase everything. Rather than do that, look at what you have, look at the definition of teledentistry and see how you can merge the two without breaking the bank before you get started.
Good point, Katrina.
So additional question, there are a couple more that came in, I think definitely could be answered by either panel, but I'll just throw one of these out at you all and see if you want to answer. But it says, how are fees structured for teledentistry visits versus a comp exam or an emergency exam completed while a provider is there in person?
For us in the schools, we get nothing for the teledentistry for the collection of data. But the dentist will then create a tentative treatment plan. Our navigators will contact the parents, and when the child comes in, then they bill for the examination.
Excellent.
And we're the same.
Same here.
And I think all of us are very hopeful that sometime in the near future, the legislature or the situation will change to where this will be an allowable billable service.
Yeah, so, and definitely if folks are interested, we definitely can talk, outside of the meeting, but there are, reimbursement strategies currently in place, and we are hopeful that these will continue post-COVID in terms of reimbursable services through teledentistry. But those currently do exist in the state of North Carolina and many states across the United States. And we're hoping that that will continue. So happy to have that conversation with anybody, outside of the meeting. So I want to thank all three of you for joining. I want to thank you again for being on camera, because that's not sometimes a comfortable place to be. But I was just amazed, and I'm not just saying it because you're on and that we're in the meeting, but I was really amazed at the footage and content that Brady was able to capture with the three of you and your teams at your health centers. And so thank you again for allowing us to do it and still trying to showcase demonstrations of teledentistry, even if we couldn't be in person.
All right, thank you.
Yes, thank you.
Thank you.
Absolutely. So what we're going to do now is actually shift gears just a little bit and move to the next panel. And so I wanted to give a little context here before we get started, but we are going to go in order. So Dr. Paul Glassman has some slides that he's going to be sharing with everyone, and then Dr. Scott Howell as well, and then Brant Herman will kind of conclude, and we'll launch a Q&A with the panelists after their content is shared. So I want to go ahead and introduce the national panel that we have arranged for you all. I was really excited. You guys, these are the people in teledentistry across the US. And so I was really excited to see that they quickly, all three responded yes, a resounding yes, I'll be a part of this. And so I want to thank you in advance for agreeing to join us today. So we're going to start with Dr. Paul Glassman. Dr. Glassman is currently a professor and the Associate Dean for Research and Community Engagement at the California North State University College of Dental Medicine, and is nationally known, quote unquote, as the father of teledentistry. And so when you think of teledentistry, I'm sure at some point you have seen Dr. Paul Glassman's name either in research and studies, op-eds, etc. He has an in-depth knowledge of teledentistry that we're excited for him to impart with us today. So with that in mind, Paul, I'm going to go ahead and turn it over to you to share your screens.
Thank you, Zach. It's great to be here. Still says host has disabled screen sharing, so I think you need to do something on your end.
Yeah, I've just got to stop here for a second, Paul, and you should be good now.
There we go. Okay, so hopefully you are now seeing the screen. And yeah, no, it's great to be back here in North Carolina, well, virtually back. So I had the pleasure of attending your first teledentistry summit, which was, I don't remember, 2 or 3 years ago. And you've clearly come a long way since then. Back then, it was sort of an idea that we should do something about this. And I'm sort of blown away by seeing all the various uses now and the advances you've had in policy. So congratulations on how far you've come.
Well, Paul, can I stop you for 1 second? I'm sorry. I just want to make sure folks are clear. The teledentistry summit, Paul, you're referring to is actually first hosted by UNC, Adams School of Dentistry. And then there was a follow-up with a joint partnership with ECU, School of Dental Medicine, and UNC. And then the collaborative has kind of worked between the lines to advance the policy forward. But I wanted to make sure that all the credit is given where it's due. So
okay, well, good. Thank you for that clarification. So yeah, but regardless of that, you've obviously come a long way. And so what Zach asked me to talk about today was to give sort of an overview of where things are nationally, and with a specific focus on something that's raised a lot of consternation. He phrased it as, is teledentistry safe? I'm sort of going to translate that for the real world. The concern that we hear a lot is about, is a teledentistry examination a real examination? So I will talk about that. But before I do that, I want to just start with actually a few disclosures. So I'm actually, as you saw, well, sorry, go back to the previous slide. I'm a professor and associate dean for research and community engagement at a school that doesn't exist yet, California North State University, is starting a dental school. And it's really been a lot of fun for me since retiring from a 30-year career at the University of Pacific to be in the process of helping to start a new dental school. I also do lots of consulting, which is the disclosures on this slide. I won't read all the people there, and there's actually lots more. So I'm pretty busy these days, lots of Zoom presentations, and which has been very exciting. And so I think this question, which was posed in the New York Times article a few years ago, is telehealth the future of healthcare? I think we're long past that. Absolutely, there's no question that the answer is yes. Teledentistry lagged a little bit behind in its initial phases of the adoption of telehealth, but I think we're moving very rapidly to have that answer be more widespread in the dental profession as well. I'm watching in the 15 years I've been doing this, I'm watching the evolution of a teledentistry actually industry, with more and more people getting involved, as you are in North Carolina, and more commercial companies getting into the business in some way with teledentistry. I'm seeing the offerings kind of shaping out like in this slide. So, and this actually doesn't even include companies that are selling primarily software or hardware components. This is actually delivery systems that are beginning to involve. And so there's a lot of use now, advice and referral. We saw some of that even in the videos that you just saw with the health centers, where you use teledentistry to talk to a patient about something, and then you give them some advice, and maybe the advice is you need to make an appointment, or maybe the advice is you're really okay, or whatever it is. So there's sort of informal advice and referral. There's more formal advice and referral. Some companies that are actually producing a call center model where someone calls with a problem, and then they can pay some money, and their dentist can talk to them 24 hours a day. And typically those end up in a referral to a bricks and mortar office, as the same as the more informal results. So then we have people doing limited on-site care. I won't talk too much about that, but at the other end of the spectrum is what I call full service care. And you saw some of that in some of the examples that were in the video just now of ways to do teledentistry so that the patient is going to get everything they need one way or the other, either through the teledentistry encounter or get to some place where the things that couldn't be done over the teledentistry encounter are done. We've actually taken that, I think, in the 15 years I've been working on this, to a little different philosophical approach, which is, and our intent is to try to produce all the health that we can in a community site where the patient is, so bringing care to where people are, and have the dental office become the high-cost surgical suite where the more complicated things that can only be done in a dental office are done. And surprisingly to me, when I first started this, I didn't know that, but most people, I'm talking the majority of people, I'll give you some numbers in a few minutes. Most people can actually have all the oral health care that they need to remain healthy in a community site without having to set foot in a bricks and mortar surgical suite, which is the dental office. So I'll quickly just show you an example of a system that I've been involved in that does that, which is, we call it the virtual dental home. So it takes the idea of the dental home and changes it from what most people think about the dental home being the dental office, and you have some outshoots, but your goal is to try and get people into the dental home, which is dental office. We've turned that around and said that the dental home is this concept that's different people in different places working together through a telehealth system. The dental office is a piece of that, but only just a piece of it. It's not the whole thing. And so we've been using both mobile and portable equipment, and I've been doing this, and I say I've been doing this now in probably 40 different, working with 40 different providers in California and in about 6 or 7 other states directly involved, and working with people in a whole bunch of other states and more sort of advice and consultation. So here's an example of a dental hygienist and assistant with portable equipment. They can be in one place one day, a different place another day, capturing a full set of images, including radiographs and photographs as needed, and producing a fully populated electronic oral health record, which has everything in it from images to charting to consent forms to health history, everything you'd expect to see in a fully electronic dental record for that patient. And so that information that's collected by the dental hygienist on site goes up into a cloud-based server where the dentist is able to get to that. And you saw some examples of that cloud-based server, depending on the software system. If you're using something like Mouthwatch's Teledent or Teledentix from the Virtual Dental Care Company, similar kind of architecture where you have the data stored in a cloud where the dentist who's not on site can get access to the records and then make a diagnosis and treatment plan. And the main decision the dentists are making is that patient able to have everything that needs to be done by the, for example, hygienist who's on site without needing to make a trip to the dental office? It turns out the answer is yes. I'll give you some data in a few minutes. It's actually yes for most people. But I'm going to just hone in on this question for a few minutes because this has raised so much concern around the country, and it really is trying to address Zach's request to talk about safety. And the question is this a real examination? Is this the same level of examination that can be performed by a dentist who's in a bricks and mortar in-person environment? And the answer is a resounding yes. I want to spend a few minutes telling you why I am so convinced that the answer is yes. So first of all, we'll start out with just what the definition of a dental examination is. The most definitive up until actually a few days ago, I'll get back to that in a minute, is looking at the ADA CDT codes where they do define what an examination is. And you can say it's a thorough evaluation of, we'll just shortcut to say records. And here's the critical part. It says that it recognizes the cognitive skills necessary for patient evaluation. Cognitive skills, this was the decision-making that's made by the dentist. So the collection and recording of some data and components of the dental examination may be delegated. However, the evaluation, which includes the diagnosis and treatment planning, is responsibility of the dentist. In other words, the dentist does not have to collect the records. The dentist just has to evaluate them. Now, that's actually something that's very common across the health spectrum. Most of the rest of the health industry is very, very comfortable now and has been doing it for a long time with different people collecting information. And then the responsible person is actually making decisions based on the information. In dentistry, we've had this feeling for a long time that if the dentist doesn't have their fingers in the person's mouth, it's not real information. But we're now moving to a place where we know that actually information collected by someone else can be just as valid as information collected by the dentist. The dentist's responsibility is to make the decision. So we did a study about this, actually a formal published study looking at decision-making, and we found that, you can read it if you want, we found that that dentists made basically the same decisions with or without an in-person examination, looking at records versus records plus an in-person examination, basically the same decisions. And in fact, the small amount of variation between those two modalities was much narrower than the variation between dentists. And we all know there's a certain amount of philosophy and art in the dental world, but the fact that there was so much more variation between dentists means that that small amount of variation between a single dentist was very legitimate to fall within the spectrum of decision making. We also know some other things, which is that based on the study, that there's a range of possibilities that a dentist could find. So a lot of people who think, oh, you really can't make a real examination, don't fully understand the process. So a dentist who's reviewing a set of records, you can think about it a little bit oversimplified, but there's some of those records you're going to look at it and you're going to say that child is absolutely healthy. You can visualize all the surfaces of all the teeth. There's clearly nothing wrong. It would be a complete waste of time for that child to come into my office and have me look and verify the same things that I'm seeing in these records and talking to the hygienist. And then there's other people at the other end of the spectrum where their mouth is just a mess. There's all kinds of broken teeth and infections, and they clearly need to come into the dental office. So the decision making really about this is kind of the people in the middle. You know, I think they have some problems, but I think based on what I'm seeing, those problems can be dealt with by the hygienist on site. And we find as dentists begin to do this, they maybe make more decisions. I'm not so sure, let's bring that patient into my office. And as they get more comfortable, realizing they're not seeing anything different in their office than they did see on the records. And so they make fewer of those decisions to bring the patient into the office. This is really based on calibration and communication. It's really based on the idea that you're going to trust the dental hygienist who's in the community to be able to, although they're not allowed to make a diagnosis, that they're going to be able to recognize deviations from normal. They're going to get you the information that you need if you're the dentist. You're going to be able to call up and have a conversation with them. It's not static. You can only look at the records. And with those sets of tools and some calibration exercises, which we always recommend when we're working with people, you can actually make a legitimate examination. And in California, we're way past any questions about it. People are doing it and billing for it. And that's the same in a lot of other states. What was fascinating to me in the last couple of days was there was a big controversy about this from the American Dental Association's House of Delegates, a resolution that was introduced that would have taken us, I think, many steps backwards. Fortunately, at the end, there was some modifications to it, and it's now a good resolution that passed by a 2/3 majority, which is pretty outstanding to have seen that transformation. I won't bring you the whole thing, but just a couple of highlighted sentences from it, which is now the statement says that the ADA believes that examinations performed using teledentistry can be an effective way to extend the reach of dental professionals. Teledentistry has the capacity to expand the reach of a dental home. And this is the critical one, which is because it really gets to the main concern that people have, is that people were using teledentistry to cut corners. And so it says services delivered by teledentistry must be consistent with how they would be delivered in person. Examination and subsequent interventions performed using teledentistry must be based on the same level of information that would be available in an in-person environment, and it is the legal responsibility of the dentist to ensure that all records collected are sufficient for the dentist to make a diagnosis and treatment plan. The reason that's so critical, that's stated that way, is the concern is people would use teledentistry to cut corners or make a diagnosis without complete information. People in the debate realize it's no easier to cut corners in a teledentistry environment than it is in an office environment. And so it was very gratifying to see this passed by a 2/3 majority for the ADA House of Delegates. And this will at some point become part of their published now policies for the American Dental Association. All right, so now back to our sort of workflow. The dentist makes a decision that this person can have some or all of the treatment they need in the community. And then depending on the state and your local environment and policy environment, hygienists can do various kinds of things. So it might be anywhere in the community, say in a school or a Head Start center or a nursing home or a residential facility. They might be able to do things like silver-diamine fluoride to stop the progression of decay. They might be able to place interim therapeutic restorations, which in several states, hygienists are allowed to do that. I think you're not there yet in North Carolina, but maybe will be at some point. Where this small hole in a tooth in a child in a low-income school typically gets nothing until that small hole becomes a big hole in a tooth and the child's in school with a toothache and maybe ending up in the emergency room. And now with no local anesthetic injections, no shots, no drilling, in about 10 minutes or so, that decay can be sealed in place. And these restorations can last as long as any other conventional restoration. So really very revolutionary, the kind of techniques we have now that did not exist when I was in dental school. So we did a proof of concept of this 6-year study, 15 communities, 3,500 patients, and we're clearly able to show we can make this idea of telehealth connected teams work. I think that's what really sort of launched the teledentistry industry in the United States. And we were able to demonstrate that we could reach people who are typically not getting care. 2/3 of children in that initial study were able to be kept healthy without needing to make a trip to the dental office. And then those who did need to make a trip to the dental office, it was much easier to get them there because they were only going just for the one filling or just for the something else that needed to be done in the office. But most kids could actually be kept healthy. And that was before we had silver diamine fluoride. And now we're predicting 80% of children and still the majority of adults can be kept healthy in a community site without needing to be physically in a dental office. So this has really started from us on the work in California in 2010 and even earlier to now in 2020. Really across the country, people are adopting systems, changing the policy environment, really catching on to the idea that where we used to think about the dental office and the dental home being in what I now call the high-cost surgical suite, and then the community side was something else. Now we realize that they can all be part of one practice, one sort of community-linked system where some part of the team is in the community and some part of the team is in the surgical suite in the office, but it's all one team, all one practice that are connected together using a teledentistry system. And in fact, I'm using the phrase a lot, the community engaged oral health system. I think we're moving towards this idea that the most effective systems to reach the most number of people and do so, keep people healthy at the lowest cost, is going to be through community engaged oral health systems. And really the golden rings of us getting there are working on these things, measurement and payment systems, delivery systems, and then using the prevention and behavior support science that I just talked about. So just a couple of words now about our current world we're living in, COVID-19. What I find fascinating in a lot of the stuff that's coming out in guidelines now is that there's a reference sometimes to this National Institute of Occupational Health and Safety chart on mitigation of risk. And if you've seen this, you realize it's got them from the least effective things you can do to the most effective. Least effective things like working with PPE and administrative controls and engineering controls. Almost all of the energy in the oral health industry is around the least effective things. How do we get PPE to everybody? What kind of engineering controls? What kind of airflow systems? But we've been thinking about really the opportunities that teledentistry offers us to work at this other end of the spectrum, the most effective things, which is actually eliminate or substitute other things. So that involves collecting records from patients and being able to evaluate them at a distance. I just added a couple of slides. I love just-in-time presentations. I added 2 slides about 5 minutes ago to this presentation because someone asked about how do you train patients to give you good records. And this is borrowed from a colleague of mine, Dr. Brooke Fukuoka in Idaho, who's actually got an instruction sheet for patients about how to take photographs of their own mouth. And we know actually, anybody who's doing it knows you can do, if a patient can take good photographs, you're going to be better able to diagnose what's going on in their mouth from a photograph than you can from trying to have them hold a moving video system. Even if you can do a snap of that, of a particular frame of the video, you're going to do better if they can take good photographs. So she's got a whole system of training patients. You notice the makeup mirror here to be able to train, take full art shots. And people get great photographs if you can train them to do that. And so we're actually doing a study now. We've started with sort of an opinion survey asking dentists about their opinion about being able to eliminate visits to their offices by using post-operative and problem-focused evaluations and all kinds of other things that don't require a visit. We're getting 20 to 30% fewer visits that dentists are guessing. We're asking about shorter visits, understanding their concerns, updating health history and demographics, and all those things you can do prior to the person coming in, again, 20 to 30%. And if you can cut down the number of visits and the length of the visits, and end up with less invasive procedures, less PPE, less infection risk, everybody's better off. So we're seeing people moving now more towards a system as people begin to understand that even in an office environment where you have to do all this highly modified stuff for aerosol producing procedures or even using minimally invasive dentistry, adding on a teledentistry component, even to a purely office environment where you can do pre and post-operative care can really enhance that practice. But once you get the idea of how to use a teledentistry system, then that opens up the possibility for some of the things I just talked about and you were seeing earlier, where you can begin to connect that office environment with the community and deliver services in schools and Head Start centers and all kinds of other places through that connected system. And also in a state like North Carolina with lots of rural areas, it opens up all kinds of possibilities, even for location of dental practices. The common wisdom in dentistry is you can't really have a practice in a rural area because there's not enough patient population. But you can start a practice there. You have a dental hygienist who's able to maybe open up a little office and then 1 or 2 days a week is in another community. Say they're renting a little space in a pharmacy or a medical office, just doing the kind of record collection and minimally invasive procedures I was talking about. And maybe that hygienist is in a different place or a couple hygienists that are working with that practice. but they're all connected to the central practice, all part of that practice. And then people who need to have the more advanced procedures will go occasionally to the dental office, although they wouldn't go there on a routine basis. And now you have a viable practice in a dental office. So this opens up a whole new spectrum of possibilities in dental care, thinking about having software systems that really support all the kind of stuff we were just talking about, opens up a whole new set of workflows to help people figure out how do you do all this stuff and knit all these pieces of the system together. Actually, but I'm spending a lot of time with myself doing these days, a lot of consultation for providers about how to do this. Happy to talk to any of you if you're interested, how to incorporate minimally invasive dentistry and how to really reach these golden rings. And now I'll just, in the last minute I have left, just talk about how do we get to a system from where we are to where we need to be. And you've already gone pretty far down the road in North Carolina, although you have a little ways further to go. And I think the challenges for all of us going forward are continued raising of awareness to help people understand what's possible. That's both inside the oral health profession and outside. Policy work that you've already begun, and that involves things about, can you actually do things, scope of practice and licensure laws, and then how do you make sure that things are paid the same way in a teledentistry environment that they're paid for in person. And then finally, implementation challenges, which even if stuff is paid for and you're allowed to do it, it's still not easy work. So again, I'm spending a lot of my time doing that now, as are others. And so that was a pretty quick overview. I hope at least I got to the point. The main point which Zach asked me to emphasize is that a teledentistry examination and teledentistry is a legitimate tool. And in fact, we can really think about community engaged systems where the majority of care takes place in the community in a much lower cost environment, much more effective at reaching and producing oral health. And the dental office is the surgical suite where you can do the advanced procedures that need to do there. So I hope that's something to help you think about the future, because I think that's where the future is going. And I think I'm 30 seconds over my time, so I apologize for that, Zach, but I'll count that as your 30 seconds of clarification from my initial beginning. So I think maybe I'm right on time.
That's fair, Paul. So thank you so much for taking the time. I think your presentation was fantastic. Not quite to where we're at right now in North Carolina, of course, but the model is something, that could be, if stakeholders are interested, strive for. What I took away from your presentation in particular, I was really excited to hear, and I know this was hot off the press, but the ADA delegate, resolution, I think that's huge for them to further recognize teledentistry as a viable option that can provide the same level of service. Coming from the ADA is huge news. So Paul, thanks for, bringing that news to us today. I'm going to move forward to the next panelist, and then we're going to loop back because, Paul, I have several questions to ask you and some that came in the chat. And so we're going to get to that at the end with the Q&A of the panelists. But I'm going to move forward now with the next panelist is Dr. Scott Howell. So Dr. Howell is an assistant professor and the director of teledentistry at A.T. Stills University at the Arizona School of Dentistry and Oral Health. He brings a wealth of knowledge, definitely, and as it relates to many modalities and applications of teledentistry in clinical practice. So he has a diverse perspective, and we're excited to hear from you, Scott, so you can go ahead and get started.
Good morning for anyone on my side of the country, and good afternoon for those of you on the East Coast. It's a pleasure to get to present and to come back to North Carolina, because I think I was at the second event, the one that happened relatively recently. I was there virtually, and that's where Zach and I kind of unofficially met. But it's my pleasure to be able to present to you and to kind of show you what we've seen and with teledentistry in action at A.T. Still University. I wasn't able to join for the first half hour there, so I apologize if there's some repeat here. But this is kind of what we have worked on and how we've advanced, or not advanced, but maybe morphed as times have changed also. So a real quick disclosure, our teledentistry project at the university was funded by a Health Resources and Services Administration grant, and then I'm a clinical advisor for Mouthwatch, but there's no financial impacts from this presentation, just information for you all. In the last 30 seconds that Paul was speaking, I threw in this slide because whatever you said, Paul, really kind of triggered in me, oh yeah, maybe this is something people would be interested in seeing. We're doing an economic impact study right now where we've sort of developed a model that we're working within and looking at how teledentistry can impact sort of the financial aspects of a dental school clinic specifically. So this isn't necessarily private practice, it's not community health centers, but what we would see in a dental school clinic. And the idea is that, 40 out of all the procedures that are done in any given day, 40% of the procedures are the ones that require the dentist and the patient to be physically together. 50% of those procedures could be done in a community setting, similar to what Paul has introduced, in collaboration with a dental hygienist. And then 10% of those procedures could probably be done with some kind of video visit like we're doing right now, maybe a treatment plan presentation, a post-op. And I think that's what you said, Paul. You mentioned how post-ops can be done. And it's a smaller amount, but about 10%. And what I found particularly fascinating is that when I looked at the revenue impacts of these procedures, 40% of our procedures are bringing in the vast majority of our revenue. As Paul said, the expensive surgical suite, yet we're bringing in non-expensive or non-revenue generating procedures. It's not that they're non-revenue, smaller revenue generating procedures, and using our expensive surgical suites to conduct these procedures. And that's where we're using teledentistry to kind of flip things on its head. So Paul, thanks for that reminder, because it reminded me to bring this in. And then again, of those 10% visits where we, post-op visits and treatment plan presentations, it doesn't bring in anything. I say it's 5% of the revenue because we do sell some like Prevident and stuff in these consultation type visits. And that's where the revenue is coming in, if any is coming in at all. So for teledentistry to work, and I hope you're starting to see some themes here, but the doctor must be accessible. I think this is the key aspect of teledentistry, that wherever the dentist is, they must be accessible. The images, the data must be diagnostic, the field team must be calibrated, and Paul mentioned this in his presentation, where whatever the dentist would physically see, the hygienist or whoever else may be collecting that data, it would also see the same things. And there's got to be trust. Paul also mentioned this, trust between dentist and hygienist. The dentist has to trust the technology. And as I tell my students, this is not something that you develop overnight. This is something that takes time to develop. Just like it takes time to learn how to do that MODL amalgam prep on number 14. I vividly remember that prep because it took me 8 hours to do when I was a dental student. It was very torturous, but it takes time. And a few weeks later, it was down to 4 hours. And by the time I was seeing patients, I could get it done in a half an hour. Okay, let's be honest, it's a dental school clinic. It still takes time. But once you leave the dental school clinic, you can get these things done much faster. And teledentistry and conducting exams via teledentistry is the exact same experience. At least that's what it's been for me. Obviously, your technology must be reliable. Your internet connection must be up and running. And I think most importantly, minds must be open. A few different modalities, which I think you all have heard about at some point or another, but similar to Paul's model, you have dentist and hygienist. We've used a model between dentist and dental specialist. And then as COVID really, I think, started growing and becoming more problematic for communities, it really became between doctors, the dentist, and directly to their patients via Zoom or other forms of video conferencing technology. My takeaway has always been, though, that there is no one model. I've had people tell me I do the old version of teledentistry. I've had people tell me I don't know what teledentistry is. Teledentistry, when you look at it, it's just technology. It's technology that allows us to communicate with our patients and our colleagues in ways that we couldn't communicate before. The challenge that I have, although I'll be honest, I have said there are people out there who don't do teledentistry, and I'm not going to name names. I'm not going to say who that is, but in my mind, teledentistry is not let me rephrase this, teledentistry cannot occur if the dentist is not part of the discussion. And the way I view that is that a dentist is a team leader. And that team is comprised of front office staff, of schedulers, of dental assistants, of dental hygienists, and in other communities, maybe dental health coordinators, community dental health coordinators. There's multiple members of this team. And if the dentist is not accessible, if the dentist is not leading the charge, to me, it's not teledentistry. Now, there could be other models that there might be a different leader, but there still must be some kind of oral health professional leader. And in all the models that I have seen that have been successful, it's the dentist. And so I really think it's important that we take away that a dentist cannot be removed from this equation. So here's a couple of the models that we use, where again, it's dentist team leader. We have the asynchronous model, hygienist is in the field site. This is very similar to like the virtual dental home, but the hygienist is in the field site, provides preventive care. At a later time, the dentist reviews the cases, coordinates the care, and delivers the care. When I say coordinates the care, this is informing the front office staff. This is saying, hey, can you contact the patient? Hey, can you do this? They may not be doing the nitty-gritty, but they are making sure the team is staying on top of things. In the synchronous model, the only real difference here is that instead of the dentist reviewing things at a later time, the dentist can meet with the patient or the patient guardian, which is the case in our patient populations I work with. We meet with the guardian or the patient via video conference, and we examine the patient then and there. But the model is basically the same. It's just when we review the data, it's a synchronous review of the data pretty much. So here's a couple examples. This is a kid in detention. He's a teenage patient in pain. The medical team who initially evaluated him said his crown fell off, but that's all we had from the medical team. And if you tell us a crown fell off, you know, as a dentist, you're like, well, is the tooth restorable? Is it not restorable? What's the oral health condition? We need more data in order to plan effectively. Our other challenge is the patient will be leaving detention soon. So the hygienist-led team goes out to the field. They collect the records that you see in front of you. There are some, these are not perfect records. I like showing not perfect things because you can see we still know what's going on, even though some things aren't perfect. And from these records, I can start coordinating care for this patient, contact our AHED, contact the front office, contact the detention center. We make sure we have the specialists available that need to be there, and we can plan appropriate amount of time. In this particular case, we do need one other data collection. We want to do endo testing because that was not completed. So we'll make sure we do the endo testing, but we're pretty sure this tooth is going to need endo and then hopefully get a temporary crown on him. We'll do what we can. We have limited time because he is leaving detention though. This is a synchronous case. This is with a hygienist who's embedded with an integrated medical dental clinic. We have an enlarged patient, a young patient with an enlarged tongue. He has a lymphangioma. He had seen a dentist previously, but the care coordination fell apart. Mom was very eager to seek care. In fact, she brought the previous treatment plan with her. So before I even examined the patient, I had a sense of what I was going to see. And what was nice about the synchronous exam is that I was able to talk with mom. I was able to see the patient through Zoom. We have a HIPAA compliant Zoom account. I was able to, with the intraoral camera, get a sense of what was going on with his teeth. You can see things are a little blurrier here, and that's because with a synchronous exam, the quality isn't, in my experience, is generally not going to be as good as an asynchronous, where the photos can be taken static and then uploaded. But I can see this kid has really rampant caries. And what I was able to do, I was then able to call the previous pediatric dentist, confirming with mom that she was okay going back to him. And she said she was, but the care coordination fell apart, so she needed things to move forward. I called the pediatric specialist and he said, yeah, I don't know what happened there. I'm very familiar with this case. He said, I'll get right on this. This case, unfortunately, was going to have to, not unfortunately, going to have to go to Phoenix Children's Hospital, but the unfortunate part is because of COVID, PCH was no longer taking any dental cases, so we were still going to be hitting some barriers. But I was able to talk to my colleague, the pediatric specialist, and say, here's what I see, what's going on, and I didn't physically need to be there. And I was able to talk with mom and get her side of things and get what she wanted, gather what her goals were to execute as best as we could. This was at the start of COVID. We had a patient who was in a rehabilitation facility, couldn't go there as a result of COVID. I reached out to him via Zoom and said, show me what's going on. We talked about what his options were. He said, I don't want to go to the dental school quite yet because the pain isn't terrible, but you gave me some hope. So I was able to at least talk to the patient, examine him. This was just one photo of the entire video conference. So I had to move his head all the way around so I could see much more. But there is some limitations to this, but at the very least, I was able to tell him what his next steps would be. So what does teledentistry offer us? It's a tool and it helps us plan. It can help keep costs down in terms of PPE for us, better use of our chair time, less travel for the patient. It helps us keep better records. If you're not going to do teledentistry, at least start taking patients on every single patient, start taking pictures on all of the patients that you work with. And it allows us to work at the top of our scopes. My hygiene colleagues who are in the field can collect the records, can provide the preventive care. My dental colleagues in the office can use their surgical skills as intended. Real quick, how do we make it successful? I'm going to show you a couple things about taking pictures in just the last few minutes here. And one thing that I can't show you in the pictures is that if you want to record a video, I have found that a 90-second video is really best to get a full quad. I don't have time to show you our video examples, but we do use videos on our comprehensive exam patients. And I think most importantly is improving our communication. If we want to make teledentistry work, whoever we're working with in the field, they need to trust us, we need to trust them. And I've always told my colleagues, if I ask something of you and it's not going to work, my hygiene colleagues, if it's not going to work, please let me know. Please tell me what's working and what's not working. I want us to be able to communicate openly and talk about what is good for our patients, what isn't good for our patients, what's good for teledentistry, what's not. And what I learned through all of this is just what my hygiene colleagues are capable of, things I never knew because I just didn't focus on that when I was working side by side with them. And they can do much more than I ever anticipated, I guess is what I want to say. These are some of the slides I put together to help my students understand how to take better pictures. I always use my non-dominant hand as basically a fulcrum. I hold the camera like a hammer, not a pen. It gives me better stability. I use the camera to retract the cheek, and all of us should know this if you've ever retracted a cheek, but this is for students. If you're not retracting the cheek as well, make sure to have the patient partly closed. And then inside the mouth, I always try to make sure the camera is parallel to the tooth so we don't get any shadows. When the camera is not parallel, you often get shadows from cusps and things like that, and that can give you false positives. It might look like decay, but it's not. The camera should always be at the angle of the arch, just so you get a nice square photo. This isn't possible in the posterior lingual because the anterior teeth get in the way. And then I always recommend about an inch away. This is a mouthwatch camera and it has about an inch focal point. Other cameras might have different focal points though. Whew, I think I went over a little bit. Sorry about that, Zach, but hopefully that gives you a general sense of what we're doing, how we're using the technology, how the technology can be used to its maximum capacity, and sort of what it takes. I know it was a whirlwind. I talked kind of fast, but I look forward to people's questions.
Absolutely. Scott, thank you so much. That was fantastic. It was really nice to see, your use of teledentistry and the perspectives. I think the main takeaway from this event, other than having these experts to rely on if you have questions and follow up after, they would welcome, that communication, but is to showcase that teledentistry is not a one size fits all. And so there are many different modalities and options for using teledentistry in your practice. And it can be as extensive or as non-extensive as you want it to be and what works best for your workflows and your practice type. So thank you to Paul and Scott. And Brant, we're going to loop you right in when we start the panelist questions. And so I'm actually going to start with you. So we're going to open up now the three panelists to a series of questions. And there are many that came in during the chat of both Paul and Scott's presentations. And I'm going to make sure that we get to as many of those as we can as well. So Brant, I'm going to go ahead and start with you, if that is okay. I do want to say that Brant is the founder and CEO of Mouthwatch LLC. I think I mentioned that earlier, but it's really exciting to have him here with us. And I want to thank you again for donating the cameras that we're going to be giving away a little bit later in the event as well. So Brant, I'm going to jump right in. I know that some folks have expressed concerns about the logistics of utilizing teledentistry in their practice. Can you walk through the typical armamentarium or the items needed to effectively engage in teledentistry?
Yeah, so I think it varies based on the type of program and effort that the program's trying to run with. Are they offsite? Are they doing preventive care offsite? Do they need some mobile equipment? We see programs that are doing something as straightforward as a screening, where they might need, some basic protective equipment and an intraoral camera, and they're just documenting the oral health condition of some kids in a school and referring that back to make some recommendations which they can share to family members and kind of bring those kids into the practice. So I think it goes all the way from full restorative off-site, where the initial appointment might be screening or preventive care that leads to a visit where restorative is being done. We see that in nursing home settings. We see that in some more advanced kind of maybe a medical clinic where they're going and bringing on the restorative side for 1 day a week or something along those lines, all the way to just real light and just documenting, helping identify issues earlier in the disease process, doing that survey, sharing that back to a dental team. And what we see is really effective. And I think, you know, with the imaging component is, even if all they're doing is reviewing the oral health of a patient and sharing back recommendations to a family member, just by seeing a magnified image of decay or some tooth issue or some oral health concern really does motivate patients to come in for treatment.
Mm-hmm. Absolutely. Yeah. I found, you know, an early step, you know, again, you can take it as far as you want, but having intraoral photos, even in office, and using that technology to show the patient, for the classic example is you have a large fracture in your tooth, it's asymptomatic. They can't see a fracture on the radiograph, right? And so when you can show them in magnification that fracture, it really does help with treatment plan acceptance and success in that perspective. So you can definitely engage again in teledentistry and as little or as extensive as you want. Brant, I'm going to move on. I'm going to ask you another question that we're commonly asked. So what are some common misunderstandings about teledentistry and the teledental workflow that you have heard from some of your clients?
So I think COVID opened up a lot of understanding of the capability of it. And I think it's really that so many different tools, so many different applications of it. I think the biggest one that we hear from providers, I would say pre-COVID, was really more about, let's say, a teleortho type approach, right? That sending some materials back to a patient, creating a treatment plan, mailing aligners, and that being considered, you know, this combination of customer service application with a dentist or provider you might not have a direct communication with, I think was a misunderstanding of that. Some people might think it's just, no, I'm just looking up a case later and that's it, or I'm talking on a phone and and that's teledentistry. So I think it's really getting people to understand it could look like the virtual dental home. It could look like a patient consultation and triage to bring them in for a more effective appointment. To us, it also looks like a referral to a specialist where you've got a patient chairside and you're streamlining communication and collaboration, you know, and it's really just the tool. You're just using the technology as the tool, that it's not specifically the service, so to speak. You're facilitating the other approaches to care coordination, care delivery through this technology. And I think once you see that's the approach, you can start doing a lot with it of now this is maybe a medical setting referral into a dental home. It's about an outreach program connecting a patient to care. So it can be all of these different services that really just use teledentistry as the backbone technology to connect patients, providers, and care.
Mm-hmm. And that's really important. And I think it was touched on by both Paul, Scott, and you, and we hear it all the time. Is teledentistry a quote unquote a thing? It's really not. It's just a tool that we're using to provide the same services that we would provide without that tool. And in many instances, as we're learning and hearing from providers across the state and country, it makes it more efficient for them to be able to deliver those services. So I think it's really important to not lose sight of the fact that we're not changing really who's at the center of that care, which Scott mentioned is still the dentist making those decisions, but we're more effectively utilizing the dentist through the use of teledentistry. And I think that that's appreciated, at least in the responses we're hearing back from our grantees that we fund for teledentistry in North Carolina. They appreciate that ability to be more efficient with their time.
Yeah, I'll just speak to that. Sorry, Zach.
Yeah,
one thing that's great, you know, when we see providers submitting claims for coverage on a teledentistry service, if someone submitted a claim and it only had a teledentistry code, a D995 or a D996, what? Right? You've got to be doing the service that's using the technology to facilitate the service.
Yeah, so I think of teledentistry codes or the CDT codes as modifier codes to some respect, how they're used in medical. And so you're really still billing out the service you're doing, but you're saying this is how it was done. So we're adding that modifier. So great point. Oh, this I don't know if this will open a can of worms for you, Brant, or not, but over the last many months that we've been dealing with the COVID crisis, have you had any like aha moments or really shock surprises from what people are requesting from you of how they want to use teledentistry?
We've seen a big uptick in facing patient teledentistry. So we had practices closed. They were trying to understand what emergency cases needed to come in. So they wanted to engage directly with their patients. A lot of teledentistry that we saw understood was more on the public health space and kind of innovative mobile programs and outreach programs prior. So there's a little less head scratching that we've seen from providers across small private practices up to large groups and programs. But I think really is the patient facing. I think they're talking about kind of a 10-year acceleration in patient behavior and a patient willingness to adopt a virtual consult. I think it really just falls into kind of what Scott pointed out and Dr. Glassman as well, of certain appointments are more convenient for me as a patient to do virtually, and they're just as, in most cases, effective for the provider. So you're getting that combination of efficiency for the providers and convenience that patients really crave, especially when you got to gear up even as a patient to go out into a setting. If you can do it from home for a follow-up, you're more inclined to.
Absolutely. So that leads me into a question I'm going to open up for all of you. What, in your experiences utilizing teledentistry in the various ways you've shared with us today that you do, have you found the patient or the consumer to be relatively accepting of this new modality? Are they flexible? Are they excited about it? Does it work for them? What would you like to say to that question?
I'd say absolutely yes. There are certainly instances where some people, because it's new and haven't seen it before, may have some initial questions, but anybody who's experienced it loves it and wants to do it again. I mean, I had a medical appointment recently and talking to the receptionist about a follow-up. It was a virtual visit. The follow-up, do you want to come in person for the next follow-up or not? And I knew it was going to be talking, and I actually laughed when she said that. I said, why would I want to go in person? I have to get in my car and drive and park and wait in the waiting room. No, there's no way I wanted to go in person. So there's no question, once people experience it and realize how it, and particularly if they realize it and it's effective, that people want to see it continue.
Mm-hmm. And so this may be a silly question, perhaps, but you're alluding to the fact that folks are really enjoying using teledentistry, and obviously the three of your experiences span well before COVID with teledentistry, but how do you see teledentistry, and this is posed to the three of you, continuing post-COVID? Because there's some rumblings of folks that are saying, well, teledentistry is going to be great, during COVID, but not really post-COVID. And so I would just like to hear your all's perspectives on that.
It's interesting. I sat in on so we have a telehealth council in Arizona, and very little dentistry is discussed because it's mostly the medicine side of things. But with that said, the Access, our Medicaid program came and showed us data that telehealth really kicked off, telemedicine specifically really kicked off. People that were never doing it prior to COVID were doing it, using it rather. And it's been dropping. And what I can't understand is why. Why is it dropping? Why could people during COVID do something via telemedicine that they can't do kind of after COVID? And we're rising everywhere, right? Numbers are going back up again. So maybe we'll see telemedicine rise. So for me, I don't know. To me, COVID has kind of expanded teledentistry. I was never considering synchronous exams pre-COVID. I thought I didn't want to try because I was like, oh, it's too much work. I have to schedule my time specifically. But I love synchronous exams. I love the ability to communicate with the guardians, to have the hygienist move the camera around so that I can see what I want to see without having to bring the patient back. I love the ability to communicate directly with a patient via Zoom. That's something we had never considered before. And we're completely revamping our triaging and our post-op and our treatment plan program within our resident clinic so that we can do more Zooming with patients. I say Zoom because that's the model we'll use, but there are tons of platforms out there. I'm by no means saying Zoom is the only one. So I think it's only opened up our mind to, wow, there's a lot more that we can be doing. Let's make sure we do that.
And Paul, you were going to say?
Yeah, let me add a couple of things to that. I completely agree. I think I have an answer. I don't know if it's the answer to the question you just posed, Scott, which is why has it dropped off? So that your data is correct, that there was an initial flurry in dentistry of dentists, and this is the ADA Health Policy Institute data, that dentists started using teledentistry in the first few weeks of the pandemic and when offices were closed. And then as offices began to reopen, the use has dropped. And my answer to that is that dentists are very used to their office practice and are trying as hard as they can to get back to the world that they were in before. And so they're really working at trying to recreate the office environment and trying to go back to where things were last year. I think that that's understandable, but I don't see it as the future. And I think it's going to come back around again as people realize all of the advantages. And I just want to just tick off just a few. The fact that I think about it as if you're dealing with something like heart disease, and someone said, okay, I got this great idea. We're going to deal with heart disease by having people make appointments and see the heart surgeon in the hospital operating room. We'll get a whole series of appointments, and we'll try and get a lot of people walk through the operating room with the heart surgeon. You'd say, what, are you crazy? That's not the way to do it. You need diet counseling, you need a lot of other stuff that doesn't belong in the hospital operating room. Well, in a sense, we've got a dental care system that's organized that way for good reasons. It has been in the past, but now we have an option to change it. And I think really one of the things that's helping to move the needle here is that a lot of dentists initially heard about and still hear about teledentistry, and they think about it as something to be afraid of. They think about it as competition. They think about it as that they're going to lose patients to this teledentistry system. Somebody else out there is going to be engaging the patients in the school. But often when they start to hear more about it, they come around to the fact that if you actually get back to the concept of a community engaged system, where the surgical suite, the office, is a part of the same system, it actually is a benefit for the dental practice. The dental practice ends up having more patients actually sitting in the dental chair than they did before, because we have the majority of our population, 200 million people in the United States, not getting regular dental care. If we can reach even half of those and get them into a system of care, everyone's going to prosper by doing that. And certainly patients are very appreciative, as we talked about, ability to do this. It's going to lower the cost in practices. And so even though right now we're seeing a lot of dentists working very hard to try to recreate the world where they're in, it's not going to be possible. We're going to be in a situation with all of this PPE and requirements. Dental practice has always been, you're doing a crown prep. In the middle of that crown prep appointment, you visited 4 other chairs to go check on a post-op here and do something else over there. You can't do that now. There's so much trouble putting all the stuff on. You can't go take it all off and go next door and come back again in 3 minutes like you used to be able to. So the idea of being able to treat everyone in your office efficiently is just, we're not going to get back to the world the way we were pre-COVID. And this opens up all kinds of possibilities of expanding practices, reaching more people, lowering the cost of care, having better population oral health. And it's just so compelling that although there's lots of implementation challenges, it's clear to me we're going to get there.
Absolutely. Scott, I had a question that came in the chat, and I want to make sure we get to this. Someone placed in, how do you feel teledentistry will benefit the special needs community? And I know that's a community in which you serve, and that's coming from a mother of 2 autistic sons. And so do you mind to speak a little bit about that?
Yeah, I think it's also tying into what Paul said, that, creating a community of care, that part of this is really engaging our patients and their families in ways that we never have before. And there's issues because we don't get reimbursed for a lot of the stuff we should be doing, like oral health counseling and things like that. But I think, for patients with special needs, there's a couple different, one example that I thought about showing but didn't was one where the hygienist, we did a synchronous exam, and I had a young woman on the other end of the camera who just would not open her mouth. And it gave me a sense before physically in the same room as hers, how are we gonna help her? What can we do to get her dental care initiated? And we knew we were gonna have to do sedation or general anesthesia. And what was nice in that sense is that I had a plan in place that didn't interrupt the patient's day like a typical visit to the dental office might do. I think avoiding some of the scary aspects of dentistry that might impact someone with a sensory disorder or something like that, where they're not around all the noises and all of this distractions. They're in their home, they're in a place they feel comfortable, and we can start developing that relationship. Let's be honest, there's no evidence. I haven't seen the evidence one way or the other, but these are things we could start exploring. I think the ability just to, again, engage with patients, engage with caregivers. Dr. Fukuoka does this with her nursing home populations, engaging with the caregivers on a regular basis to see, hey, how's brushing going? How's that? How's this? Things that, again, it could be the dentist, but really ideal for a hygienist, someone who prevention is their day-to-day, right? And I think when we can take people out of the dental office, because the dental office, even if you don't have special needs, can be very overwhelming. When we can take that aspect out of the equation and we can meet people where they're at, it really helps with them engage with the process. So I'm excited to see what we can do. And I know the young boy that you saw in that picture, he has medically complex issues, but he loved being on camera. He was fascinated with it. He loved watching himself. I mean, kids really enjoy technology. And I think especially a lot of people who communicate through technology, a lot of our patients who communicate through computers and things like that, this is going to fit right in with the world that they live in too. So there's multiple avenues. We haven't explored them, but I'm excited to.
And I can add just a couple of things about that. I have a picture actually in a slideshow if I had a longer version of what I typically talk about, which is a young man in his mid-20s with intellectual disabilities who had all of his previous dental care done in a hospital operating room. He would walk into a dental office and he would just be nervous about it, and the dentist would look at him and say, oh, this guy's not cooperative, he needs to have care in the operating room. When we started the virtual dental home system, we had a hygienist who was able in his home environment. It took a couple of desensitization appointments, but he got to the place where he could allow her to have full records taken of his mouth, x-rays and photographs and everything else that needed to be done. She could do all the preventive procedures, including the interim therapeutic restorations, and he may never have to go back to the hospital operating room again. And this is you can't think of a more dramatic change from someone who was having all of their care in the operating room year after year after year to never having to go back again. So that's kind of an extreme example. We've also got a project going in California. We're calling it Remote Oral Health Support, where we're working with people in our social service system for people with disabilities, with hygienists now doing through video conferencing, basically, because they can't actually go into the residential facilities, but doing remote oral health support, everything from just helping the caregivers with brushing to mailing fluoride varnish and instructing them about how to place it, to even placing temporary fillings, that the kind of thing that a caregiver can do on site. So there's all kinds of things I think we can do to make the lives and the health of people with disabilities, particularly in some kind of organized system, better through teledentistry.
Mm-hmm. And Scott, you were speaking earlier, and I really love, the theme of trust, having trust with the person on the other end, whether that be your hygienist or whoever that is. Do you yourself, you've been engaging in teledentistry for quite some time, do you trust the photo and video content you receive to aid you in making a diagnosis?
If I don't trust it, I don't make a diagnosis, is how I feel. So if I don't trust it, and if it's something that is a result of the technology going wrong, we get to the issue there. If it's because now keep in mind, I work with dental students who are trained to use the cameras, but don't, they're still learning to use the cameras. So in that situation, I know I'm not going to necessarily get the best photos all the time, but the hygienist who's out in the field works with them and tries to improve them while they're there. If I have what I need, I make the diagnosis. If I have, the vitality testing, the periapical testing, the x-rays, the radiographs, the photos, if I can see the entire tooth in its entirety, then yeah, I'll make a diagnosis. So if I can't make a diagnosis, does that eliminate the need for teledentistry? No. What it does is it tells me, okay, what do we need to improve? Again, do we need to fix the technology? Do we need to fix the collaboration between the hygienist and dentist? Or is it just that maybe I have 90% of my diagnosis and I can make a clinical impression, if you will. I learned that term from a periodontist in Michigan. And then we can still come up with a plan. Like the case that you saw, the one with the lost crown, we didn't do vitality testing. We're not sure that tooth needs endo, but based on the patient's complaint, it's waking him up at night, it's constant pain, we're leading towards probably needing endo. So we can prepare for that procedure. It's there are times, having worked with plenty of special needs patients, this is my analogy. When we bring a patient with special needs in who isn't going to open their mouth, we can't see inside, we can't take x-rays, we wait till we get to the sedation appointment. It doesn't mean we don't do the initial appointment. We don't jump right into the sedation. And that's where I view teledentistry. Teledentistry can give us that initial data. And then if we need to, we'll collect further if needed.
Gotcha. And can I just add something to that? I think I want to underscore it because what Scott said was just so important. It really was the basis of this whole thing that just took place in the American Dental Association's House of Delegates and the resolution and the way it originally got introduced and the way it ended up at the end, which was much better. It really is based on the idea it's a dentist's responsibility to make sure they have enough information to make the diagnosis and treatment plan. If they don't have enough information, they've got to get more. And getting more, it could be just telling the hygienist who's out in the school, I can't really see the distal of the last molar. Can you take one more x-ray, or can you take another photograph, or can we have a conversation about it? I see a little brown spot there. Can you tell me if that brown spot is hard or soft? So there's lots of things that a dentist can do to get more information. So it's, I think that's a common misconception. The dentist is going to look at a computer screen and that's it. You're not allowed to have any more information, yes or no, on this particular, that's not the way it is in the real world. And so I think that's really critical for people to understand. And the other thing I think it's critical to understand is it's exactly the same as in a dental office. If you're in a dental office and you have an x-ray where you can't see the distal of number 14 and you think you should, then you ask for another x-ray. So there's nothing different about a teledentistry environment in this critical thing that Scott said, which is the dentist has to have enough information, and it's up to the dentist. It's their legal and professional responsibility to make sure they have enough information to make the diagnosis or to do the steps to get more information.
Mm-hmm. Absolutely. It makes me think of what we hear from our providers across the state, and that's one benefit of teledentistry, in particular asynchronous teledentistry, that they love is, in a dental office, the exams are scheduled, and sometimes they're quick in terms of the volume of patients that you have on your schedule. When they're having a chance to pause and rewind and rewatch over and over, or magnify in with images coupled with radiographs and video, they feel that they can actually make a more accurate diagnosis often, is what we're hearing. Does that jive with the three of you, what you're hearing from your providers or your research, Paul, that you're finding?
There's published data to back up what you just said. The dentist can actually make a better diagnosis looking at a good image than they can looking in the mouth. There's data about that's 20 years old. So, right. but there has to be some context around that. It has to be the right image, and it has to be in the right context. And I want to just add one more thing, if I may, about this issue of trust. I think maybe it's clear in what we were just been talking about in the last few minutes, but the dentist really does have to trust the hygienist to be able to recognize deviations from normal. There's no way that the hygienist is going to take a photograph of every square millimeter of the mouth. And the dentist has to trust that they've got a hygienist who, if there's something that needs to be called to their attention, the hygienist is going to call it to their attention. And so that does take a trusted relationship. It takes realizing you've got a trained professional at the other end. It takes some calibration. We often recommend that dentists at the beginning of a relationship like that, they go examine a bunch of patients together, have the hygienist examine a patient in their office, collect the same records they would if the patient was 50 miles away, and then the dentist go in and look at the patient's mouth and say, oh wait, you forgot to take a picture of the upper arch, or whatever it is. I'm being silly, but to make sure that they're, and if they next time that brown spot, could you write down whether it's hard or soft? It'll just save me having to call you up and ask you. So the trusting relationship in having a professional working relationship is critical to this process. Mm-hmm.
I wanted to add one additional piece, and I think Bill Donigan may have had to jump off the call. He was so nice to join us. He was actually on vacation with his wife, and so he joined us from our mountain area in the state. But he's not. I don't think he's not on any longer. If you are, Bill, feel free to unmute yourself. But one example I wanted to give, I've actually had this experience in clinical practice myself multiple times, and that's around the pediatric patient. And so we would get calls, little Susie's tooth, the gum is bleeding and the tooth isn't where it used to be, or the tooth is moving, but it's not coming out. And so I need to come in for an emergency. And what we often find in doing synchronous teledentistry is that's a retained deciduous tooth that's just attached to gingiva. And so that you're then able to walk that parent or guardian through how to handle that situation without them actually having to come into the dental office. And that's not uncommon. I saw that a lot when I was using teledentistry in clinical practice. Does that mirror, Scott, experiences for you or Paul?
Yeah, I think the one thing with the synchronous, kind of this synchronous direct to patient, I think there's a difference synchronous with hygienist and synchronous direct to patient.
Mm-hmm.
The synchronous direct to patient, it really is, it's the diagnosis aspect of that is a little bit trickier because we don't have the same clinical photos and stuff. But I think it's exactly that you can get a sense of what's going on. You can, talk to the parent. You've seen this before clinically. You know what this looks like. You can reassure them, hey, let's walk through this together.
Mm-hmm.
To add to something Paul had said about the data is there, I will say the one area where I haven't seen data is, do we have enough from patient collected data to diagnose? And that is an area where we need to continue exploring these patient either asynchronous data collection, like Dr. Fukuoka's pictures that Paul showed, where it was, patients taking their own photos, to like what I had with my patient, where he's complaining of pain in his lower tooth and I'm just giving him some suggestions for what to do. We are still somewhat limited, but when people can reach out and have a conversation with their dentist or their hygienist, that continues to build the trust and the relationship and maintain it when we are separated by things like COVID. So it's so crucial that we don't eliminate those from our repertoire, from our toolbox, just because we're not used to them, because they truly can continue to help our offices and our clinics thrive.
Absolutely. And I could go on for the next 26 minutes we have left about clinical examples of how teledentistry I've engaged in with my patients that have really serviced the patients well and me well in terms of efficiency. One other example is, I do a lot of oral surgery. And so sometimes quick post-op checks that you want the patient to come in for can be done via teledentistry instead of the person having to take off a day or a half a day from work to drive into the office for a 15-minute appointment. Can be done during their lunch hour at work. And so I've engaged in that way in teledentistry multiple times. It has been very successful. I know that we had a colleague at UNC that Dr. Sean Matthews, that I think you all have met at the previous summit or symposium for teledentistry in North Carolina. He's now moved on to the University of Indiana, but he's an oral maxillofacial surgeon. And so that was kind of what he used teledentistry for. So it goes back to this idea that it's not a one size fits all approach. And teledentistry, again, in quotes, is not a thing. It is a tool to use to still do the same quality and level of care that you would do in person. And that is validated through research and data, as Paul had mentioned. So I want to thank the three of you again for taking the time to join us for the panel today. It was amazing to hear your perspectives. I think the panelists, you guys gave such great opportunities for follow-up from participants. And so, Kelsey, if you can put in the chat just the link, we just put your bios and your contact information in one sheet for participants, and so they're able to follow up with you after if they have any specific questions that didn't get answered. I'm going to open the floor one last time before we move on to wrap everything up. Are there any burning questions for the panelists?
Zach, I just want to add one point. That data I showed is not peer reviewed. It's just really raw data as we are in the middle of our project. So just to clarify that's still in the process of being worked up. That's all I want to share.
Yeah, I appreciate it. I was referring to Paul's data in terms of his study.
Oh, okay. Yeah.
Yeah, but no, I appreciate you clarifying. So any other questions for folks at this time?
I did have one quick question, and my question was, what is the turnaround rate from seeing a patient virtually to getting them in the clinic? Is like a high rate of people who are coming back to the clinic in person to get a checkup and get those procedures done, or are people not coming back after having that virtual meeting?
No, I have.
Go ahead, Paul.
Yeah, I have some data about that from our big initial 6-year demonstration. But I'd say the first answer to that question, it completely depends on the system you're working in. There's so many different ways to organize things that you'd get a very different answer how you were doing it. But in the system that we had where we were doing that virtual dental home concept, we found that that was before we had silver diamine fluoride. So it was about 2/3 of children could be kept healthy at the school. Only about 1/3 were decided by dentists that they needed to go into an office. And of that third, they needed to go into an office, about 2/3 of those actually made it to the appointments. So we found we had complete care on about 85% of the population. So it wasn't 100%, it was about 85%. We still had another 15%. We just could not get them into the dental office in spite of trying. But that was talking about we were working with very low income populations where before we had the system, their rate of getting dental care was 15 or 20% complete care. And to take that from 15 or 20% to 85%, even though it wasn't perfect, was a huge, huge advance.
Yeah, our experience has been just because the populations we work with, they have transportation, so kids in detention, men in rehab. The biggest challenge we have is with our kids with special needs on Medicaid. You know, some of these kids have upwards of 200 medical visits a year. So they just have competing, priorities really, or their parents and guardians might have competing priorities. So it does take, it's not the teledentistry aspect though. It's simply because these kids have other priorities, or their needs, they have other needs rather. So I think what's really important in all of this is that, as I mentioned, the dentist kind of coordinates care, but it's really important that you have a patient care coordinator person, whether it's a front office person, someone like that can really stay on top of these cases and stay on top of the workflow, because people can fall through the cracks. We had one patient who came in, had two treatment, that two things that we had to do, some endo and extractions, got the endo done, but never came back. We don't know what happened. Well, his entire family got COVID. So obviously he couldn't make it to the clinic. Another situation, the kid, he actually had a job and he just was always working, and we were having trouble working around his work schedule, even though we scheduled him 3 times and there were always these no-shows. So I say he's a kid, he was 18 years old, but so I think it's crucial to have someone that can stay on top of the cases, because it is remote and maybe you aren't seeing them. You might feel it's not as easy to keep track of. So just have a system in place that works for your clinic.
And I would add to that, I think that, again, you keep saying these very important things, Scott, so I'm just underlining them, but the care coordination, I just want to emphasize that if you're going to actually have a robust system where you're reaching out into the community and you're having a team of hygienists and the people in the community, and some of them are going to need to come into the office, you've got to have some care coordination built into that. It's just, if you're going to have a full service system of care coordination is a lot of ways to do it, but you really have to think about that in your design of your system.
And I think even to that point, when you have that patient-facing messaging and component to the platform you're using or whatever approach, it makes it easier. You're almost care coordinating directly with the patient, where it's streamlined. It's easier for them to ask that question or follow up or let you know what that issue might be.
Excellent. Well, this has been super helpful again. I really appreciate all 3 of you joining and spending your time with us today. I'm sure there will be quite a few questions that come in and follow up that's needed after. And so I'll make sure to coordinate and connect folks, or they'll reach out directly to the 3 of you. So thanks again for joining us with the panel.
And thank you for inviting us, and all the best for your work in North Carolina.
Absolutely.
Yeah. Take care, everyone.
All right, so I'm going to get us back to the schedule here. And so we are now going to dive into the intraoral camera giveaway. And so Kelsey, I'm going to let you kind of take the reins here.
Sure. Hi, everyone. Thanks so much for being with us today. So we have a mouthwatch camera that we are going to, we have 4 of them, that we have raffled off based on who is here currently, and that was registered for the event. So our 4 winners today are Cindy Ashley from the Wilkes Public Health Dental Clinic, Natalie from Mayheck, Lakeisha Moore from NCDHHS, and Nancy Ferguson Brown, a volunteer dental hygienist at the Good Samaritan Clinic. So congratulations to you guys. I will be reaching out via email with the one that you registered for the event with, to connect with you and see how is best to get the camera to you. And if you do not plan, if you are not related or connected to a clinic and you would like to donate it to a clinic of your choice, we will figure that out with you offline. So thanks so much, everyone.
All right, awesome, congrats. I don't know how Kelsey does her magic with her randomizer. She'll have to show me that after the event, but congratulations to the folks that were selected. And we hope that the intraoral cameras do service your patients and your clinic staff well. And Brant is still on the call, so I just want to thank you again, Brant, for donating those to us. That's a huge help.
You bet.
All right, and so we're going to move on here as we wrap up. We mentioned in the agenda we're just going to be talking about next steps for North Carolina, and so I wanted to just reemphasize, you probably have heard this on part 1 of Oral Health Day, but the Oral Health Collaborative really was able to have a nice partnership with the North Carolina Dental Society that included about 40 different stakeholders through a teledentistry workforce, or task force rather. Many of the folks on this call are on that task force also. And so we were able to comprehensively draft legislation for teledentistry that we're looking to move forward with in long session 2021. And so I just wanted to make folks aware that that is occurring. We had so much feedback that we incorporated into the draft, and it was a very diverse and collaborative effort. So I want to thank all the folks that were involved in the crafting of this legislation, and also a huge thanks to the North Carolina Dental Society for their support and partnership in really leading this effort. So that's where we're at in terms of legislation. And I always leave this quote up, when we have events, because I think that it is so important for us to remember that, that legislation, for example, I mentioned, had over 40 different stakeholders represented, and they were representing their organizations or agencies as well. And so this was a huge collaborative effort to get this done. Nothing happens in a vacuum. And so individually we're one drop, as we know, and together we're an ocean. Little cheesy, but I really love this quote, and you see it all the time for me. So if you ever get tired of seeing this on any of our presentations, just let me know. But it really speaks to the core of what the Oral Health Collaborative is. We want to engage each and every one of you in the work that we're doing in partnership with other agencies across the state. And so we definitely encourage you all to reach out and get involved. And how you do that, we try to make it as simple as possible, but my email address is listed at the top, as well as our program email address that Kelsey and Brady both filter through and respond to very promptly. My cell number is listed. That is my actual cell number. I have never been prank called or prank texted at this point, and please don't do that, but that is my cell number. So, always reach out if you have questions, if you want to chat through anything of the work that we're doing, or maybe what's happening in your community. You can text me, call me, email me, as well as engage any of the staff at NCUHC. They're happy to help. We are on Twitter, Facebook, and LinkedIn. And then newly launched, Brady was able to get this up and running to make it easy. If you want to join our email list and get our news, you can text the word teeth to 917-905-8801, and that will allow you to join our listserv. And so we send out correspondences twice monthly, and then sometimes in between, depending on what initiatives we have going on. But I wanted to open the floor. We have a little bit of time. I don't know that anyone will be sad to give you back 15 minutes of your Friday, especially when it's beautiful outside. And so I am here, and we'll hang around if there are any additional questions. So just kind of opening it up at this point. If there aren't any questions, there is a post-event survey that Brady has just put into the chat. So the link is in the chat at this point. And so we will be sending a post-event email to everyone, thanking you and giving you an opportunity to respond in our survey. So please take the survey and let us know if there's something about the event that you would like to see differently next time, or aspects that you found particularly impactful. I hope that you did find it impactful, but definitely let us know that in the survey, and we can always modify events in the future. So if there aren't any questions, I'm going to go ahead and sign us off and give you back 13 minutes of your Friday.
What's popping? And boy, is it popping. How many views have you had so far?
All right, everyone, take care.
Thank you.
Bye-bye.
Thanks. Have a good weekend.
Thank you, everybody.
Thank you.